And today, what I'm going to share is some of the findings on voice therapy with children. And this study is in collaboration with Dr. Estella and also Dr. Jacky F.W. On the project. So this project is under a big umbrella, the Green Voice project. And for this pediatric population, we call it 健康之聲, so style of healthy voice. And the data, the results was recently published in Journal of Voice. For those of you who are interested in looking into more details, you're very welcome to either talk to me after the conference or go to Journal of Voice and get a copy of that paper. So what I'm going to share with you is some data looking into the effectiveness of voice therapy. When we talk about voice therapy, we have two aspects. So vocal hygiene education and a vocal facilitative techniques. So these results will be talking from the speech therapist perspective. And as you all know that voice problems are very common in children. If we look into the literature, we find a wide range of prevalence of childhood dysphonia reported in the literature from 6% to over 30%, depending on the methodology of how researchers define voice problems and also how they measure and calculate the prevalence. Anyhow, voice problems can lead to significant negative impacts on the child's academic, social, and also psychological well-being development. So we know that they are being negatively judged by listeners in terms of their personality, in terms of their intelligence and social characteristics. So the impacts on the child can be significant and also long-term that they cannot and should not be underestimated. When we look into children, and I want to focus more on school-age children, the majority of voice problems are associated with phonotrauma. So phonotrauma is a term developed and proposed by Professor Kitty Bertolini in the US. It talks about those mechanical impacts on the vocal folds during phonation. So it's phonotrauma. And the behavioral treatment is generally considered as the first line approach for managing voice problems in children. As I mentioned earlier, there are two main aspects. So one is vocal hygiene education. We work with the child and identify those vocal misuse or overuse pattern in their daily life. And then we work with them, through a kind of, education and games so that they know what is good, what kind of habit, what kind of voice use habit is good for their voice. And we also work on those effective voice production. And one of the examples of those techniques that we always work with children is resonant voice treatment. So the resonant voice therapy is the aim is to facilitate and promote the production of a clear and strong voice with the least impact on the vocal folds during adduction. So in that sense, we hope to reduce phonotrauma and therefore improve voice. Now, if we look into literature, there are a number of studies that look into the effectiveness of voice therapy for children with vocal nodules, and these are some examples. What you can see is that the majority of those studies, they didn't include the control group. We have one recently published in 2018. It's quite a large scale study that compared direct versus indirect treatment. So in the terms of RCT, so the direct treatment is including those facilitative vocal techniques, particularly resonant voice, and the indirect is more like vocal hygiene education. Now, in our study, we evaluate the effectiveness of vocal hygiene education together with resonant voice therapy in a group of children with vocal nodules. We compare this treatment approach against two groups. One is the placebo control, and the other is no treatment control group. I'll tell more about what kind of placebo program we used in this study. What we hypothesized is that we would find significantly greater improvements in outcome measures that would be shown in children who are assigned to the treatment groups than the other two groups. So in the study, there are altogether 17 children, including 9 boys and 8 girls. The mean age is 7.5 years old. All of them, they presented with vocal nodules diagnosed by Dr. Siu and Dr. Low. And they did not have any history or presence of speech, language, and hearing, behavioral problems, etc. And they did not, none of them have received any kind of formal voice treatment before attending our treatment program. So these 17 children, they are randomly assigned to 3 groups. The treatment group, who received 6 weekly sessions of voice therapy. And again, that voice therapy comprised of vocal hygiene education together with resonant voice training. So with resonant voice training, we train them to produce a resonant voice like and then starting from that sound, we call it humming, and then progressed to, and then me, etc. So in that sense, we promote forward resonance, and that will reduce those kind of, laryngeal tension during the voice production. Those children assigned to placebo group, they received 6 weekly sessions on presentation skills training. So it's kind of reading and presentation skills training, whereas those assigned to non-treatment, no treatment control group, they did not receive any form of treatment over that 6-week period. So this slide shows the sample protocol in more details for the treatment group and the placebo group. I took example from lessons 3, 4, and 5. As you can see, the training are pretty much comparable in terms of the format between the treatment group and the placebo group. So for the treatment group, for example, in session 3, children practiced a resonant voice at the disyllabic level. And how about for those assigned to the placebo group? They practiced reading disyllabic words, so 2-syllable words with clear articulation. In session 4, children in the treatment group, they practiced resonant voice at the sentence level. So comparably, those in the placebo group, they practice sentences with different tones and emotions. So in that sense, we're training their presentation skills. What we aim to control is that between the treatment group and the placebo group, there are similar amounts of clinician interaction, as well as the amount of talking time. There are a number of measurements that we used as outcome measures in this study. The first is the voice-related outcome measures. We used the Pediatric Voice Handicap Index, the PVHI, which is completed by the parents. And then we also include the Children's Voice Handicap Index, which was completed by the child himself or herself. So we want to get a sense of, their perception versus the parents' perception. We also use the acoustic perturbation measures and analyzing sentences in terms of the acoustic properties of those voice quality. And we also use the auditory-perceptual evaluation looking into the overall severity, which is always considered as the gold standard when we talk about analyzing and measuring the overall severity of the voice problem. For the schedule, we evaluate these outcomes. We collected these outcomes pre-treatment versus post-treatment. And the assessor, so those who took these outcome measures, they were not aware of the children's group assignment. So we hope that that kind of blindness would enhance the validity of this study. So let's look into the results. Now, these are those outcome measures, and these are the results for the treatment group So those children receiving vocal hygiene education and resonant voice treatment. And then results for the placebo group, that means children who receive presentation skills training, and those children who were assigned to the no treatment control group. So for the voice-related quality of life, so in other words, those functional, voice performance, functional aspect, if we look into the results of the Pediatric Voice Handicap Index, we found significant improvement in the treatment group. If we look into the parents' perceived severity, we found a significant improvement in terms of the perceived severity level after treatment. For the total PVHI score, there is also a significant decrease in the score, in the total PVHI score post-treatment. That implies significantly improve in the quality of life. There are no significant differences pre and post treatment for the PVHI score for the other two groups. Now, for the Children's Voice Handicap Index, there are no significant difference for all the three groups and the acoustic measures as well, which is actually makes sense because children, when we talk to them, do you feel like, you got a voice problem? How would you rate your voice problem? And they would, totally no idea. They always feel like, even though they have a husky voice like this, they don't really, not many of them will feel like they have a voice problem. And if we look into the acoustic measures and, the use of acoustic measurements to, to measure voice severity, and, if we look into the voice literature now, there are more and more, evidence showing that the acoustic measures doesn't really always correlate with the voice quality. So we are pretty happy with this results. However, when we look into the perceived overall severity, which is the perceptual evaluation by listeners. Remember, we have 4 listeners doing the perceptual voice evaluation. And the perceptual voice evaluation, they were done using a paired comparison paradigm. So how we did that, we present a pair of voice samples to the listener. One is pre-treatment of that child, and then the other sample will be the post-treatment, the post-sample of that child. So the listener have to listen to both samples and compare, are there any differences between the pre and the post? And the severity ratings, they will rated in the range of from -3 units, which means the most negative change. So that means at the post-treatment, there's a, a more severe voice, if that is a -3, to +3, which indicates the most positive improvements. So if we are looking into this data, we're looking for plus signs, in the data, which means good. So for the treatment group, we found plus 0.7 units in the changes of the perceptual voice quality. So that is good. We're very happy about that. For those children assigned to the placebo group, now that's the presentation skills training, there was a deterioration of their voice quality after treatment. So that's also, quite matched with our perception. What's really interesting is for those children assigned to the no treatment control group, so supposedly they didn't do anything between the two assignments, between pre and post measurement. But we found that this group of children, they have some improvements in their voice. So what happened? So let's look back to the treatment group first. This group of children, they received vocal hygiene education. So they know they were being taught on, and also their parents, they're being taught on what kind of voice use habit, what kind of daily life, habits are good to their voice, such as more hydration, minimize the amount of yelling, screaming, etc. And also resonant voice therapy. So they learn about the voice, those techniques that would minimize inducing any tension in the neck and promoting forward resonance. So what we know from what we can suggest from the results is that these combination, the vocal hygiene exercise together with resonant voice treatment, they are effective in improving parent perceived voice related quality of life. So functionally, they are more, much more better. They felt much more better with the voice, which was reflected in the improvements in the auditory perceptual overall severity rating. And this is consistent with our hypothesis. Now, in the placebo group, children in this group, they received placebo skills training, and we found deteriorated voice quality at post-treatment. However, no change with the voice-related quality of life. So that's a kind of placebo effect. We would take it that way. And we also, from data, we would imply that the reading and presentation activities did not aim at optimizing voice production. So it's natural that they're not meant to have any therapeutic effects on the dysphonia. So what happened to the no treatment control group? We found some improvement in the perceived overall severity, but no change in voice-related quality of life. Our question is, why improvement in voice quality? Some of you may think whether that is an issue related to the perceptual evaluation, because that's subjective judgment. We'll say, yes, maybe, but I have to stress that the listeners who conducted those perceptual evaluation, they have received perceptual training before rating. And from the ratings, we found pretty high ICC values. In terms of the intra-rater, we got 0.84 and inter-rater is 0.73. And if we look into the perceptual evaluation literature, there's quite satisfactory reliability. What we thought is that it may be related to the subject recruitment process, especially in Hong Kong. Those parents who join our programs, they're more motivated parents. And so they're more aware of the child's voice after the voice assessment. They're very, very motivated, and they would keep an eye, very close eye on what kind of assessment that you do. And they look around, the assessment, the lab, and they would, they may get some more information. So we thought that perhaps voice assessment alone may be sufficient to lead to change in voice care knowledge, attitude, or even practice. And we're very interested that we want to look into further whether this is the case. So for further directions, we want to recruit larger sample continuously with the hope of having multi-centers in Hong Kong. And we also want to evaluate any change in vocal nodule size at post-treatment point. Many of the children, after they received the voice treatment, then they ran away. So it's hard to really get them and scope them. So that's all I want to share with you. Thank you again for having me here, and I welcome any questions at the end of the session. Thank you.